You're listening to the Doc Lounge podcast. This is a place for candid healthcare conversations with physician recruitment industry's top executives and thought leaders. This podcast is made possible by Pacific Companies, your trusted advisor in physician recruitment. My name is Summer Gilbert, and I am the Director of Marketing and Branding here at Pacific Companies. Today on Provider's Perspective, we're going to learn more about Dr. Andrew Bazakis' journey through medicine. Dr. Bazakis is a board-certified emergency medicine physician practicing in Saginaw, Michigan. So thank you guys for tuning in. Now let's learn more about Dr. Andrew Bazakis. First of all, I want to thank you for taking the time to be on the Doc Lounge podcast today. Really appreciate it.
Of course.
So let's go back to the beginning. What made you want to go into medicine?
So I describe it as it's kind of like the same way I met my wife. I was in college and I was looking for some kind of a major and I had to come up with something. And so I put down pre-med somewhere on some paperwork somewhere, because back when I went to college, stuff was on paper. And and because science seemed interesting and I generally liked people. And so I spent a little time with the curriculum. And then after I got some exposure to the practice of medicine. And then after a while, the next thing I knew, I was in love and there was no turning back. And so it's kind of like how I met my wife. And she was kind of nice and interesting. And the next thing I know, I was in love and there was no turning back. So so I fell in love with medicine pretty much the same way. There were a few formative experiences. I think spending some time in the hospital with some mentors was absolutely key, because there's nothing like being there, as they say. In terms of intellectual stuff, I was really influenced by the writings of Oliver Sacks, who was a neurologist from Columbia and wrote some books for the lay press that were really about neuroscience and how lesions in the brain and various other things affected personality, how the brain works in regards to music. He wrote The Man Who Mistook His Wife for a Hat. He wrote Musicology. He wrote An Anthropologist on Mars, and a lot of really neat stuff that really turned me on to neuroscience and the interface between the mind-body interface. So actually, when I went to medical school, I thought I wanted to do either neurology or psychiatry. And then that probably goes into your next question. How did you end up doing emergency medicine?
Yep.
And it was similar to the same story I said about my wife. I really, I was exposed to emergency medicine by a fellow named Tom Tarter, who was on a television special that tracked a bunch of Harvard medical students. He was a former Olympic weightlifter. And he happened to be training in Lansing, Michigan, where I was in medical school, and gave a talk and described his experience in emergency medicine. I thought, this is really kind of cool. Let me check this out. So I somehow found a way to hang out in the ER at Sparrow and Lansing on a couple of occasions. And I thought, wow, this is really cool. And I kept my mind open during my clinical years, but there was just so much about it that I absolutely just fell in love with. And even though I still love neuroscience, and my work in simulation actually allows for that to come full circle around, there were so many things about emergency medicine that really were just so captivating for me that once again, the next thing I knew, I was in love and there was no turning back.
So it sounds like you've had no regrets for choosing emergency medicine, but if you had to change your specialty right now, what would you go into?
Sure. I mean, I tell the medical students that specialty choice, it's kind of like getting married. It is a long-term, life-impacting decision made in a short period of time with limited information. There's a great deal of uncertainty, and after the fact, it's very expensive to change your mind. Mm-hmm. And there are maybe not one perfect choice, but it's more important to avoid maybe some choices that are very bad fits for you.
Yeah.
So find some of the fits that are good fits for you, maybe one that's the most optimal. And I actually have a whole talk I give to medical students about this, the various rubrics I give them to help them sort this out. But knowing that you're going to sort of carve out of that, within that variability, something that works well for you. And if you see a specialty later on that you think, God, that would have been really cool, it doesn't mean you made the wrong choice. It means you made a choice.
Yeah.
Right? It's kind of like when you get married, and I'm married to the most wonderful woman in the world. She is just so fantastic. Does that mean that you don't run into somebody you think, wow, she's really neat? That would have been really cool. Yeah, it doesn't mean you made a wrong choice. You made a choice. Now, I think I made the optimal choice, but that's my bias. But and specialty choice is much the same way. So are there other things that I could have done? Sure. I mean, emergency medicine, we really are true generalists. We see anyone, anything, anytime. And family practice has that about it too. They see anyone, anything. The anytime thing, well, if you count the hospital, yeah, that could very well be true. So I think that was the attractive thing about family practice medicine. But I really just loved acute care medicine so much. That hit me in that direction. I think in interventional cardiology, that would have been really fun too. You really get a chance to make an impact at, a time that is really critical for the patient. And that's one of the things that attracted me to emergency medicine. You can make a huge difference at a critical moment, and interventional cardiologists have that about their practice too. So that was very attractive to me about that.
Yeah.
There were a couple of different things that you think, wow, that would have been kind of cool, or this would have been kind of cool. And I really enjoyed just about every rotation I was on.
Yeah.
But, one of the places where I really found the best fit was in the emergency department. And so, are there regrets? I don't know about regrets. I mean, do you look back and you have thoughts? Sure. But man, I shouldn't have done this. No.
Yeah.
Other than the fleeting moment of, oh my God, what is this?
Yeah.
This is bad for me. It's 2 a.m. and I'm awake. But that's part of it, right? Right. You have a baby. The same thing's going to happen to you. I have 3 wonderful kids. Were there times when they were little and they were up in the middle of the night? Yes. But you know what? You embrace that because it is what it is.
Yeah.
And it's a joy to be able to do it.
Yeah, absolutely. What would you say you like least about emergency medicine?
Well, emergency medicine does have a lot of great stuff about it. I mean, there's a breadth of practice. There's a certain amount of flexibility to it, in terms of, when you're on shift, you're on. When you're off, you're off. And you can make a difference at in a critical moment in people's lives. And you get the first crack at the diagnosis, that's also something that a lot of emergency physicians love about their work. But what are the risks to emergency medicine, right? What are some of the things that are just the realities of things? Well, shift work is both the upside and the downside. Right. The nice thing about shift work is when you're on, you're on. When you're off, you're off. And when I leave the emergency department, no one's paging me to return to the hospital. It's one of those types of things. Even if I'm late after my shift is over, finishing things up, taking care of patient needs, finishing paperwork, whatever it is, when I'm done, I walk out, I get to that parking lot, I get in my car and I leave. It would be a very rare event to get a call to return. So that part is nice. The downside of shift work is we have a civilization that has a very reasonable expectation for healthcare 24/7, 365. Someone's got to be there in the evening. Somebody's got to be there at night. Someone's got to be there on the weekend. Someone's got to be there on the holidays. So in emergency medicine, you work nights, you work evenings, you work weekends, you work holidays. Your family will be doing holiday stuff and get together stuff when you are working or sleeping to recover. And so there are real considerations about that. It's one of the downsides to shift work.
Yeah.
You're grocery shopping on Tuesday afternoon when much of the rest of the world is doing business hours, and get out of the store a lot faster if that's important to you. So there's really cool things like that. But you may be at work all night Tuesday night. And I spent 16 years as a nocturnist working only night shifts. And so there's upsides and downsides to it. So it is very much a two-sided coin. The other thing about emergency medicine that I encourage students to consider is what I call toxic exposures. There are both 2 types, physical toxic exposures and psychological toxic exposures. Physical toxic exposures, well, some of them are circadian rhythm disturbance, right? Because you're not going to have a regular job schedule. Typically, your circadian rhythm will likely undergo some disturbance. That is bad for you. It is very bad for your health. We would never recommend that to our patients, but it is part and parcel of it. Is it better than being on call? I think so, but some people might not agree. There are other specialties that you have more of a daytime sort of schedule. Emergency medicine is not one of those. You're also exposed to a lot of physical disease. The whole COVID-19 epidemic has high nurses, paramedics, EMTs, all of our nursing staff, respiratory therapy, radiographers, all the folks in the front line are putting themselves at risk. But we also understand that that is part of what we signed up for. That is part of the risk that we take when these events occur.
Mm-hmm.
You're also exposed to more violence. It is not unusual at all for nursing and physician staff to suffer assault. Sometimes it is in the context of someone acting out behaviorally. Sometimes it's people who have issues with their mental health and they really have no idea what they're doing.
Yeah.
And so there's some of that too. But trauma is trauma. And so there's that risk as well. As well as exposure to disease, airborne, bloodborne in general. You're using sharp objects such as needles to sew wounds. People get needle sticks, and there's all the things that go along with that. So that's one of the things that we take into account. There is exposure to physical toxins. There are also psychological toxins to be considered. People come to see us on the worst day of their life.
Yep.
Every shift you can expect to be exposed to suffering and disease and likely death. And seeing that much of that in such a concentrated form on a regular basis is not representative of most people's life in our society. So it is, there's a certain amount of psychological strain that can create. And what we do with that and be able to cope with that effectively is essential in emergency medicine for physicians, nurses, paramedics. It's also true of, firefighters and law enforcement, and all these other folks for whom, because of where we interact with people in society, the realities of the human condition are not muted in any way.
Yeah.
We need to develop a very strong sense of wellness to cope with this. We also have a job where you are very high risk for litigation, that you can do your very best. You can be extremely careful. There's not an ER doc I've ever met that does not really truly care about every patient they see. But things are going to go wrong from time to time. There are things that are going to get missed. There are bad outcomes that are going to occur. And then when lawsuits are filed, that's a whole wellness issue in and of itself, and being able to cope with that whole thing. And then all the other issues of autonomy of practice is the third thing to think of. The golden era of the physician having complete autonomy over their practice, the independent practitioner, that is going away. Now, that was never such a big deal in emergency medicine, but there were independent staffing groups who would contract with hospitals or systems. And while those still do exist, those smaller groups are really giving way to larger mega groups, because that's the only type of structure that tends to be able to survive in the current environment of expense and regulation.
Yeah.
And so that can be at the cost of a sense of autonomy of practice. The documentation that's demanded, those demands only go up and up and up over time. That's just one example. Thank God we have scribes and other such voice dictation, other such things to help us with that. Now, is that a reason not to do emergency medicine? None of those are reasons not to.
Yeah.
But we have to be realistic that when we consider that, that we keep those things in mind, that we keep those factors in mind, so we're not surprised, right? So like when you're looking at a spouse and their best friend tells them, he's a great guy and all, but understand he struggles with A, B, and C, you should know that signing up.
Yep.
Yep. And it's the same thing. Emergency medicine obviously has so many awesome things about it. I've been doing this for 23 years. I intend on doing it for many years more. So there's awful lot good about it, more than there is a challenge, but we have to be realistic about the challenges too. And those are some of the risks. And I try to make sure the students, when they are rotating in the ER and they're considering emergency medicine as a specialty, that they're aware that so that they can make a mindful choice.
Yeah, you got to be proactive with the information that you know about what you're going into, than reactive. It's going to help you. So talking about exposures, what are you seeing right now with COVID?
Well, in my particular community, we have, I gotta say, I'm at Covenant Healthcare in Saginaw, and Saginaw County has done an amazing job with preparing for this. We have had the distinct advantage, however, of seeing what happened with our colleagues on the East Coast and then in Detroit and then working its way north to Flint. And so by the time it got to us, we had time to really get our ducks in a row and prepare. Our emergency medicine and critical care staff is amazing. Our respiratory therapists are some of the best I've ever worked with. Our nurses are phenomenal. Our administrators have just, pulled out all the stops, and we've really been able to absorb a lot of the shockwave of this, where the curve has been flattened out. We've never gotten to the point where we've needed a ventilator and not had one, which is the whole point of flattening the curve, is just to not overwhelm the healthcare system. And we have been able to be very successful in that, into provision of protective equipment for staff, and really pulling through all of this together. So I have to say I'm very, very proud of what the job that my institution has been able to do.
Yeah.
The state of Michigan has been hit reasonably hard. My empathy goes out to anyone in leadership during a time like this. It's great uncertainty out there.
Oh, yeah.
And we're taking it all one day at a time.
Yeah, well, I totally understand that. And I can't thank you guys enough for being on the front lines for us every day like you do. And I have a question for you regarding masks, because there's a big debate about, is it really doing anything to wear them all the time out in public? What are your thoughts on this big mask debate?
Sure. There's the recommendations from any particular community, of course, vary from one community to the next. I think the thing that we would do best to look at as a guiding principle is to use some common sense, right? To be very patient and extend a great deal of grace to our fellow citizens. If people are wearing masks and want to keep a distance, then we really should extend some grace to that. If folks maybe are not comfortable wearing masks for various reasons, or maybe they have a hard time, people with respiratory diseases of some sort, it's very hard for them. We should also extend a certain amount of grace to those folks too, and maybe we have to keep a certain amount of distance. And so I think a great deal of grace and consideration and kindness will go a long way, and to allow common sense to be our guide more than fear. And there's reason for fear. There really is. But when we take a moment and we step back and, forgive the pun, take a deep breath, and we act in the principles of common sense and kindness, we'll probably make better decisions.
Yeah, definitely. So circling back away from the COVID discussion, you are a husband and a father. How do you balance your time being a physician and a family man?
Sure. And I'm very glad you asked that question, because I don't like to look at, I am not crazy about the whole illustration of balance. I really like to think of it more as it's more like an interwoven tapestry than it is one thing weighed against another. It's as if your work is one part of you and your life is the other part of you. And I don't know, and I think that's a bit dichotomous. And dichotomies are very helpful sometimes, but sometimes they can be a bit inaccurate. And it's my view that this is one of those times when it can be. Your two most precious resources are your time and your attention. And how those interweave between your work and the rest of the way you spend your time and attention, which people call their life, well, those are kind of interwoven together.
Yeah.
And I don't know that they're weighed one against another necessarily. So, how do you interweave those in an optimal way? I think that weave changes over time, because life is not static. When we are young, and perhaps we are, we don't necessarily have a family of our own yet. And by that, I mean, we don't have a partner and children necessarily yet. How that tapestry is woven may be different than when we, have young children, maybe different when our children are teenagers or grown. And so how those weave together. And so how do we do that? We really try to keep in mind, what are our values and what are our priorities? What is the most important thing to us, and weaving that into our life, so to speak, life, quote unquote, and our
Mm-hmm.
work, quote, where really those are much the same. And those values, I believe, should be integrated between those two. The
Yeah.
values should be the same between those two, because we are integrated human beings. Not that we don't have a work persona and a home persona of sorts, right? There is some truth to that. But those integrated values should never change.
Mm-hmm.
And so integrating those two as to where you are based on what's important to you is very, I think that's where the heart of that is, and helps to guide those decisions. When you understand what Simon Sinek calls your why, right? Your purpose. Why are you doing what you do?
Yep.
Once you can articulate that and take that from the subconscious brain into the conscious brain, and you can look at it and use it as a measuring stick, then those decisions become an awful lot easier.
Mm-hmm.
So, like for me, people are the most important thing on the planet, other human beings. That's why I practice medicine. That's why I have my marriage. That's why I have my children. That's why I engage with my neighbors the way I do. That's why I do everything I do, because the most valuable thing to me is other people.
Yeah.
And how do you create that balance? I don't know that it's a balance so much as things that are interwoven together.
Yeah.
And when that tapestry is just not being woven in a way that seems to flow well, then we step back. We look at what's
Yeah.
important to us. We look at our purpose. We look at our why, and that's the chance to realign the decisions that we make, to make those things aligned with those purposes and those values.
Yeah. And I look at your why, and beyond being a husband and a father and emergency medicine physician, you have your hands full in other special projects. Tell us more about those.
Well, one of the other professional hats that I wear is I'm core faculty for our residency training program. And my area of almost subspecialty, or the area that I really spend a lot of my time with, is in high fidelity simulation as an educational tool for residents training to become emergency medicine specialists. And I think that's a really exciting thing, because
Mm-hmm.
what it does is it allows some of the most intense opportunities for coaching and leadership development that exist in the medical training experience over the course of 3 years. And what that has been able to do for the most deliberate and accelerated growth learning that our residents have been able to experience has really been phenomenal. I have seen the capacity of my residents as resuscitationists and as leaders, both in and out of the department, just explode since this program has really taken off a few years ago. I did not launch this program. I am standing on the shoulders of giants, of those who came before me.
Mm-hmm.
But the platform itself is incredibly powerful and edifying, and really bolsters the ability of the resident to grow an immense amount in a very brief period of time, with some really insightful and expert coaching opportunities in an environment that is psychologically safe.
Mm-hmm.
That's not to say it's comfortable. Growth is never comfortable, but it is psychologically safe, because even if they make a mistake in the lab, the mannequin's fine. Right?
Yeah.
The mannequin's fine. And then we can break that down, and we can find out where that came from, and we can fix it.
Yeah.
And we can even more importantly, give the resident tools that they can use to repeat that process over time to grow themselves to clinical mastery. And every patient deserves a master clinician. I don't know a single physician that I've ever met who disagrees with that. And every one of us
Yeah.
would want to pursue clinical mastery.
Just to interrupt really quickly, the mannequins that you guys use, I mean, is the technology on that just insane? I mean, to actually mimic health issues in our bodies is mind-blowing to me.
It's a whole other world. It really is. I mean, when you go to these international simulation conferences and you see these vendors that are providing these mannequins that they offer for sale, it's unbelievable how some of these can create such amazing fidelity. A lot of people are familiar with the Annie mannequin that we all used for CPR class, right?
Mm,
That was
yep.
sort of one of the beginning stage mannequins, right? We have gone so far beyond that now. I now work with a pediatric mannequin, which is about the size of a 6-year-old boy, that will talk to you and track you with his eyes and his head movements around the room. And that fidelity is really important, because it really helps to bring out a lot of those very visceral subconscious reactions that we have when interacting with patients and families. Because that's something that really can't be taught in the textbook. And that art of medicine is so essential and so important, that it's something that really is a very rich opportunity that exists in that simulated environment. But yes, it is a whole world of its own. I have great admiration and respect for the engineers that put these things together. They're not, and the people that put these together, they are artists. They really are. Art is something that helps us bridge the gap between the known and the unknown. And really, we look at these things and we think, how did that happen? That's amazing. And so it really helps to bridge that gap.
Wow. Yeah. And continue on. Tell us more about your peer coaching.
Yeah. So one of the things that I noticed in the course of medical training, when you're a medical student and you're going through your preclinicals, then you're in your rotations, and you have, various people observing you and providing you feedback and mentoring you and whatnot. And then you get into residency and you have an assigned advisor, but then your staff is supervising you and watching over you. And then you get done and you go off and and maybe you do fellowship where there's some sort of supervision and guidance and mentoring. But once that residency and fellowship is done, you're kind of off on your own. Here you go. You're self-made. Go on your own. And then that process just comes to a grinding halt, and you're expelled. The thought is, you don't need any more of that. You're kind of on your own. And while there is a certain amount of truth to that, when you're finished with your training, have you attained really peak clinical mastery? I don't think so. That's true. You're at a point where you can really take charge of your own accelerated learning at that point. But one of the things that's missing is the presence of real-time peer feedback in that environment. And several of my colleagues from various parts of the country have noticed this. And so there's an opportunity to provide some sort of peer mentoring from other physicians that, you've been out of training for a while. And in the academic research realm, this is much more popular. And not so much popular in the clinical realm, but you do see little islands of it that I would really like to see that expand. But an ability to essentially have a peer coach is essentially a partner who is willing to think along with you. And when you have two minds sharing, thinking about a problem or a process or a research project or professional goals or whatever it may be, two people thinking together, and someone maybe observing from the outside, they can provide you insight that you're not going to come up with on your own. I heard someone once say that a third party can tell you things about yourself in 10 minutes that'll take you 40 years to figure out by yourself. And that's actually quite true. Philosophers of the mind referred to this, part of this as the first third person problem. The one person who can change what you do is the only person who can't see it. And that's you. And that's, and athletes have been doing this forever. When we think about it, right? You have elite golfers that have golf coaches. Tiger Woods has a golf coach. One of the best golfers in the world. He's got a golf coach. Tom Brady can throw a football like nobody else. He's got a throwing coach. Serena Williams, born in Saginaw. I had a little plug for Serena Williams there. She's a tennis coach. You think she can't play tennis? Of course she can play tennis. She's one of the best in the world. Because the athletes understand that to keep their game moving further and further into mastery, it's important to have that third-party feedback. Now, do we really think that Serena Williams' tennis coach can beat her in a tennis game? Probably not.
Yeah.
Do we think that Tiger Woods' golf coach can beat him on the golf course? Doubt it. But they can provide something that those particular elite athletes can't. And so in the athletic world, in the music world, in many of these other places, the idea of third-party feedback in terms of active coaching has been used quite extensively to help these folks develop mastery on a world-class level. Why should that not be brought into the medical world to help us continue to accelerate our clinical mastery to a world-class level? Patients deserve that.
Yeah.
And so that's something that I'm very passionate about. That's already been built. We just need to apply it in the medical world. And it's already being done in the research world, because that's a place where folks are open to these new ideas. They tend to be early adopters in the research world. And I think it's a matter of time. I hope and pray it's a matter of time before that's adopted in the clinical world, because I think great things can happen. And it also appears that those experiences can also enhance physician wellness, promote resilience, and decrease rates of burnout, in addition to promoting clinical mastery. It reinvigorates the enthusiasm of practice from those that I've talked to that have done it. So that's something that I think is a really great thing that we can hopefully look forward to in the years to come.
Yeah, I love this idea. And when you first talked about it, I was thinking this is for students, but it doesn't matter what level of a physician you are. If you've been, working for 30 years, a second pair of eyes is priceless.
For thousands of years, learning the art of medicine was a mentorship, right? We read Hippocrates. I always joke that one of the reasons why the original Oath of Hippocrates isn't used in medical schools is because there's an admonition there not to charge the students. The medical tuition scheme would then go completely under. So I will not charge my students for passing it along. But the point is that it's designed to be a bit of a mentorship. You can teach biochemistry in mass. You can teach physiology in mass. You can teach anatomy to some degree in mass. You cannot teach the art of medicine in mass. That is a small group, at least, if not a one-on-one mentoring interaction. It's for folks who are parents. You get this. It's one of those things like when with your kids, you hear the phrase "more is caught than taught." Well, with much of the art of medicine, that is just as true. And so that mentorship and that coaching and that feedback is really, really essential to really growing physicians that are that have clarity of their purpose, that have mastery of their clinical craft, and that are resilient in their practice.
Yeah. And speaking of mastering your craft as a physician, I mean, we're just talking about mannequins that can simulate human beings. The fast growth of technologies happening right now is amazing. It's awesome. But as a physician, how are you keeping up with it? Do you find it overwhelming? I mean, anything from, new technologies to EMR systems, new methods. How do you personally keep up with this ever-changing medical industry?
Sure. Technology is a tool like any other tool, and it needs to be taken for what it is. Now, in terms of the knowledge base, yes, there has been an explosion. There is a fantastic podcast out there called The Skeptic's Guide to Emergency Medicine that's done by a fellow named Ken Milne. I've never met him. I'm a listener and a fan. And one of the things that he has described is that in the last 15, 20 years or so, or certainly when I was in medical school back in the 20th century, what was called the knowledge translation window, that is the time when research is published finds its way integrated into clinical practice, is 5 to 10 years. Well, thanks to the internet and certainly social media, it's now down to about 6 months, maybe 12. So you can imagine how that accelerates that. And I can credit Ken with bringing that to me. It totally blew my mind and gave me some perspective. So that's one of those things that gives you a sense of how fast it's going. Now, emergency medicine, being true generalists, we touch the first couple of hours of everything. That is only amplified. So keeping up on just the knowledge expansion, given the knowledge translation window, is a task in and of its own. Fortunately, we have been very, very much blessed with some superb technologies. There's a number of just fantastic podcasts out there. There is actually a company out there that EMRAP that produces probably some of the most impressive continuing medical education that's the most easy to access and up to date. It's phenomenal what these folks can do and how they have taken on this monstrous task and done it so extremely well. So there are people out there in the emergency medicine specialty that are leveraging that same technology that created that explosion to address the needs of that explosion. There are other things too that are very different than when I trained. Ultrasound and its use is just a different thing. When I was a resident, almost nobody did ultrasound back at that time. Now, especially in the critical care type of scenario, it's like your stethoscope.
Yeah.
It becomes part of your physical exam. In the trauma bay, it becomes part of your physical exam. And my residents are amazing with ultrasound. These guys are running around with butterflies in their pockets and have an ultrasound literally in their pocket. And so not all of them, but there are some of them that are. And it's amazing what can be done with ultrasound and how that enhances some abilities to perform procedures more safely, how that enhances our diagnostics, especially in the critical care scenario. And, and so that technology is fantastic. It does create an opportunity and even a need to expand one's skill set. But there are definite benefits that come with that. And so we know that in emergency medicine, you're going to run hard and you're going to be, putting in the time and work to keep up. But that's where it is. And it's it's an extinguishable skill set. If you step out of clinical practice for a year or more, certainly two, it's very, very hard to return because that rapid expansion. So a lot of us really take very seriously keeping up. But a lot of that technology really is just super. The knowledge translation window shrinking has created a knowledge explosion, which is good, and that we now know and understand things in ways that we never did even 10 years ago. How we treat stroke, how we treat cardiac arrest. I mean, so many things that we do so much better than we did even a decade ago because of that. And with that comes the challenge of keeping up. But I think the emergency medicine community has, and the folks at Hippo EM in particular, but many other folks that have done also some great work with podcasts and conferences and various other things. My God, just unbelievable production of resources to help the emergency physician do that.
Yeah. So we're already almost out of time, but this is a question that I usually always end a provider's perspective with because I love the variety of answers that I get to this question. What advice do you have for those physicians that are finishing school and entering the physician career world?
Well, depending on where they are, right? If you have young folks that are doing their undergraduate training, probably some of the best advice I could give them is spend some time in the healthcare arena. What we think of in our heads and what we see with our eyes when we're there can be different. And that's important to get a sense of what you're looking at. There are some folks that I went to undergraduate school who changed their mind partway through their training because they realized they really liked science, but medicine was not the way to pursue science that they thought it was. So it's really important to get that sense of that type of thing. And then if you are going to engage in a healthcare career, there's all different kinds of healthcare professions out there. So, I mean, there's medical school, there's nursing school, there's PA school, there's respiratory therapists, there's nurse anesthetists for folks who've gone through nursing school first. There's all kinds of different options, and exploring those is really important. For those that are in medical school already and find themselves there are a few things that I recommend that they look at and sort of rubric questions they ask themselves to help with their decision. The first is, where do you like to spend your time? Do you like to spend your time in an office setting or on the wards or in the unit, or maybe some kind of a hybrid in the ER, or maybe even out in the field like pre-hospital physicians do, or sports medicine docs? The operating room in particular, do you love being in the OR?
Mm-hmm.
Because one of the decisions that we make, do I want to be a medical doctor or a surgical doctor? If you absolutely love the operating room, like one of my classmates who became a general surgeon said, it felt right. It felt like it was where I was supposed to be. And that's a subconscious mind feeding all kinds of things back into the consciousness. And for him, being a surgeon was absolutely the right decision. And so if you love being in the OR, that's a reason to be a surgeon. If it's okay and it's neat, but it's not really just wow and all that, then that doesn't mean you shouldn't be a surgeon, but that's maybe a reason to consider more maybe medical specialties as well as surgical. What kind of disease processes interest you? That's the other question I ask them. If you're the kind of person who just, really is into the development of people from, birth into adulthood, pediatrics could be your thing. If you're the kind of person that, really, loves, endocrinology and physiology and things like that, then maybe being an endocrinologist or, maybe even nephrology is more your gig.
Mm-hmm.
If you're somebody who likes all different kinds of things, family practice or emergency medicine or some other generalist specialty like that could be more a good fit for you. How do you like to work with your hands? That's the third question, because we all work with our hands in some way, shape, or form. If you're going to be an internist or a critical care physician or a neurologist, you need to have amazing physical exam skills. Sometimes it gets a little bit more particular, like the surgeon obviously has to have very particular mechanical skills in terms of performing a particular procedure. Orthopedists in particular have to have some of the most intricate skills in putting together fractures and that happen in bones that don't follow any particular pattern necessarily. They've got to figure it out and it's got to work. So how do you like to work with your hands? The fourth question is, where does my personality fit? Emergency physicians, there's variance among us, of course, but there tend to be certain personalities that gravitate there. General surgeons tend to be a certain kind of personality. Pediatricians tend to be a certain type of personality. And where do I fit? Where do I find that, this is kind of my group. These are my people.
Mm-hmm.
And also, we got to be honest with ourselves. The people we spend time with, we become more like them. It's back to that spouse advice, right? Pick a spouse that you want to become more like them, because you're going to spend around time like them. You're going to start using their expressions. You're going to start making the same faces. You're going to become more like them. So pick somebody that you want to become more like. It's the same thing with a specialty. And one of the things that drew me to emergency medicine is the ER docs I had met in medical school were some of the coolest people I had ever run into. I ran into great people in all specialties, don't get me wrong, but they were not only really fantastic doctors, but really down-to-earth human beings. And they also, a lot of them had interests that were so well developed outside of medicine.
Mm-hmm.
And that was part of the depth of their personality. And that drew me to emergency medicine. The other question that I tell people to ask themselves, medical students in particular, where did I have the most fun? This is really important. It's more important than people realize. Again, that's your subconscious brain talking to your conscious brain, because you have spent a great deal of time and energy to pursue a profession. You have sacrificed a great deal. You have a mortgage without a house, or you owe Uncle Sam a lot of cash. Or time. And your 20s are probably gone if you went straight through undergraduate school. So you've made some serious sacrifices. It is absolutely reasonable to have a job that you really enjoy. I enjoyed a lot of my rotations. I had the most fun in the ER. And I think that should not be discounted. If you have a job that you love to do, you're going to do it well. And the final thing I tell them to consider is, if you have people close to you, a spouse, siblings, your folks, what do they say about how you seemed during various different rotations? Where did you seem the most happy? I had a classmate who was married and had children when he went to medical school, and his wife told him, you were home more during some other rotations, but when you were on your general surgery rotation, when you were home, you were so happy. You were so excited about your work. this really seems to be what you love. And when you're home, it was awesome. And it was like it was never home, but there were overnight calls and things like that involved. And he became a
Mm-hmm.
general surgeon because that feedback made a big difference to him, because his wife obviously could see things about him and confirm things for him that he may have questioned about himself or maybe not even seen.
Yeah.
And he's a fantastic general surgeon. So get the insight of people close to you, because they know you, they see things about you. And we all should have those few people that are close to us, that short list of
Mm-hmm.
people whose feedback we strongly consider.
Yeah.
Disregard everybody else, but that short list we should
Yeah.
definitely think about. And
That's
so those
great.
people we should ask.
Mm-hmm.
So those are the rubrics I give to medical students. I actually have a whole talk I do on this for them. But those are the rubrics I give to medical students to ask themselves the answers to those questions, knowing that there's no perfect specialty choice. It's important to know when a specialty choice is not a good fit for you, but to help find your way to a specialty choice that really would work for you and that you can create and carve something out of over the course of your life, that will be a fulfilling career that you can serve your patients
Yeah.
and your community well.
Mm-hmm. Absolutely. And I feel like a lot of physicians, sometimes they get this financial blinder on because they have this big debt. And so they're looking at the specialties that pay the most. And they'll, consider that first before where their passion lies. Do you see truth in that?
And I've seen people fall into that trap, and it typically does not work out well when they do. Now, that having been said, finances are a real consideration. You've got student loans that will stay with you until either you're dead or they're paid, because it's the way that the law works around those. You can bankruptcy away just about everything else, but student loans you really can't. So there is a real sense of pressure regarding that. And one of the things that I advise medical students to do is, while that is a real consideration, truth be told, if you love what you do and you're good at what you do and you have decent financial advising and even any sense of, and you can really get a sense of some financial self-discipline, for those first few years, you're going to be fine.
Mm-hmm.
And so to consider that as part of the formula. Now, if you have two specialties that you're weighing out and they're really 6.5 dozen and one pays immensely better than the other, okay, sure. I can see that might tip the balance in that direction. I would imagine that to be an unusual situation, but I don't have any data, so I can't say for sure.
Yeah.
But truth be told, if we love what we do and then we're going to get really good at it. And when we get good at it, we will do fine.
Yeah. Well, what great advice. Thank you so much for taking the time to share that and to share your journey. I hope that those listening can, gather something from your experience and just be entertained by hearing your journey. And I think that's the kind of the beauty and the magic of these providers' perspective episodes is not necessarily learning something new, but being able to relate to another physician's story. And then obviously those residents and fellows, or maybe upcoming physicians listening, to have some guidance and get some inspiration and be inspired by these podcasts. So, that being said, Dr. Bazakis, thank you so much for taking the time to be on the Doc Lounge podcast.
Super. Well, I really do appreciate the opportunity. I hope I can have been of some help, and I will be sure to subscribe to your podcast.
Awesome. All right.
Thank you so much.
Have a great rest of your day. Bye. Thank you to all our listeners. If you'd like to be notified when new episodes air, make sure to hit that subscribe button. And a big thank you to Pacific Companies. Without you guys, this podcast could not be possible. If you would like to be a guest, go to www.pacificcompanies.com. Thank you. Absolutely. And I feel like a lot of physicians, sometimes they get this financial blinder on because they have this big debt. And so they're looking at the specialties that pay the most. And they'll, consider that first before where their passion lies. Do you see truth in that?